Hello.
Yeah, thank you, all speakers. We have two topics. One is head and neck cancer, and the other one is SCC. And we are very happy to welcome a professor from Chung Ho. We just have a MOU between Chung Ho and Chorei. And we all know that SCC is very common in both countries, Vietnam and Taiwan. And as in the speech of Dr. Sorry, Dr. Chan?
Yeah.
Chan. Dr. Chan. Yes, we can see that the vaccination of HPV started in 1984, and now the incidence of SCC is decreased. And we hope in Vietnam we have a similar vaccination program, but after 10 years. So we hope we can have a lower incidence in the future. And in the talk of Dr. Phạm Tuấn Anh, we can hear is SCC is still a big problem in Vietnam with a lot of new medication, but the survival is still low. So we can have a discussion to share experience how to improve our caring for the patients in Vietnam and also in Taiwan. So I have a question for you that you have the Taiwan guidelines for SCC, right?
Yeah, that's right. Yes.
So in Chorei, we can have the surgery, the TACE, RFA, microwave, and also the liver transplant. So what is your opinion in combining between the local therapy with with the new treatment is lenvatinib or ICI? Yes.
So thank you for your question. Of course, currently, I think the target therapy, so lenvatinib or the ICI, now I have said that we have several kinds of combination therapy with ICI, with atezolizumab or you know the medication. So of course, currently, the National Health Insurance have emphasized that if you want to use this system therapy, you cannot do more by the local regional therapy for this patient. That means when a patient cannot receive local regional therapy or any other kind of therapy, you can move to the systemic therapy. I think this is, of course, not very, very good strategies for patients. So sometimes we currently, particularly, I might show in my slide, if you use the local regional therapy, the first one, you may control the major tumor. Of course, you may try to control the tumors in the liver or the metastatic region. Sometimes the oligometa or something like that. You may try to use local regional therapy or even surgery, etc., to try to manage the maybe the major tumor or some lesions you can treat. And the others, of course, by the system therapy, we want to try to cure the patient, not only in the liver, of course, the other sites. So we now have also the strategy to use the reimbursement of the National Health Insurance to treat the patient by system therapy. Then we try, maybe sometimes we combine with the TACE, which combines with RFA, micro, and wave ablation, etc., to try to do that. Of course, there are some reports of talk about the radiotherapy. For example, this morning we can talk about the radiotherapy. We can talk about the proton therapy or even the heavy ion, etc. So you can try to also you combine this one to treat the patients by multi-modality or multidisciplinary cooperation. And the others, I think, since the patients can use the treatment by National Health Insurance free, so we use the major system therapy free for patient. then maybe add something, patient have to pay. This is also the condition I think we Taiwanese have to try to overcome these barriers about the burden of economy of the treatment. So I think it's time to consider multimodality, multidisciplinary cooperation of the patient. So I think the LIBOR team or the HCC team should invite all the related oncologists or the other radiologists, etc. I think this is most important. So this is an era of cooperation. Thank you.
I would like to ask you, what about your opinion about the adjuvant systematic therapy after the radical operation, after phase? What do you think about the future role of the adjuvant? Yeah, like TKI or ICI adjuvant.
So of course, currently there are some trials have shown that try to use the system therapy with the paradigm shift to left. That means the earlier one. Indeed, currently we use the TAC if the patient is multiple. For example, in Taiwan, we do 3 times of TAC. If fail, you can use the National Health Insurance reimbursement of the system therapy. So we'll try to treat the patient earlier with 3 times of local radiotherapy TAC, and then if cannot, we just abandon, just give the system therapy. Let us talk about now maybe the adjuvant or neoadjuvant, etc. Earlier study for the treatment that we have published in KMU, if you with operation of the early lesion, however, have microvascular invasion, you can use sorafenib target therapy. Indeed, in a small scale study, we have find the effective prevention of recurrence. However, currently, most major study tells that maybe not. But I think if this patient get operation or surgery or the local treatment, indeed have microvascular invasion, etc., I think the risk is very high. So maybe we need a more large-scale trial to confirm this point. Currently, somebody used the TAC combined together with the system. I think, I hope, and I wish, and I believe it will maybe work. That may be the future, maybe progress of the therapy. How do you think?
Okay, I will think so. I agree with you. But we need more evidence about the adjuvant after phase, after operation. Yeah. And we hope that it's effective, to kill more the HCC. Yes.
And do you have any question from the audience? Yes. Yeah, please.
Sorry, because we're quite limited in the micro.
Dạ em chào thầy, em muốn hỏi thầy Phạm Tuấn Anh ạ. Trong cái bài nghiên cứu của thầy thì viết về các cái điều trị toàn thân ở tại bệnh viện K ấy. Thì hiện tại thì em thấy có cái cập nhật bộ đôi STRIDE với AB thì cũng chưa có cái nghiên cứu đối đầu nào giữa hai cái bộ đôi này, và cái OS của hai cái bộ đôi này là một AB sẽ là 19 tháng và STRIDE sẽ là 15 tháng, thì cái tiêu chuẩn đầu vào em thấy cũng không giống nhau ấy. Thì Việt Nam mình cũng em thấy cũng đang băn khoăn giữa hai cái đấy, nó liên quan đến vấn đề kinh tế của bệnh nhân nữa, lựa chọn bước 1 nữa. Thì em có thể hỏi thầy về cái kinh nghiệm của thầy đối với bệnh nhân, tiêu chuẩn cá nhân hóa bệnh nhân đối với từng cái điều trị của cái này không ạ? Dạ em xin cảm ơn ạ.
Vâng, cũng rất là cảm ơn câu hỏi của bạn. Thì đúng như bạn nói thì cũng không có những nghiên cứu đối đầu, do vậy là mình không đưa ra được kết luận. Nhưng mà các cái nghiên cứu, các hướng dẫn điều trị quốc tế thì của NCCN hay của ESMO thì họ đưa cả hai cái đấy và đều là prefer cả. Thì cái việc hiệu quả thì nó cũng không chứng minh được là cái nào tốt hơn, thì mình sẽ dựa vào những các cái về mặt hồ sơ độc tính và cái sự sẵn có, cũng như là cái vấn đề về mặt liên quan đến tài chính. Thì thông thường là những bệnh nhân nào chúng ta biết là dùng cái bevacizumab thì có một số những cái chống chỉ định, chẳng hạn như là các nguy cơ, đặc biệt là những bệnh nhân mà ung thư gan Việt Nam này lại trên nền bệnh lý gan mạn, trên nền xơ gan, và những bệnh nhân mà có tăng áp lực tĩnh mạch cửa, có nguy cơ giãn vỡ thinh mạch thực quản. Do vậy bao giờ là cái bevacizumab thường là những bệnh nhân mà có chống chỉ định với thuốc kháng sinh mạch như beva, chẳng hạn như là nguy cơ mà về mặt xuất huyết, hoặc có liên quan đến cái việc mà dùng các cái bệnh lý về đông máu hoặc huyết khối, hoặc là dùng các cái thuốc liên quan chống đông hoặc là tăng huyết áp và những cái độc tính mà không kiểm soát được, và protein niệu chẳng hạn. Thì những cái trường hợp đấy thì chúng ta sẽ sẽ cân nhắc là sử dụng cái bộ đôi miễn dịch. Nhưng mà thực tế bộ đôi miễn dịch thì hai thuốc miễn dịch thì cái cũng mới có ở Việt Nam, và cái chi phí thì cũng là một cái rào cản, và do vậy là nếu mà để mà lựa chọn cái phác đồ nào thì ngoài cái vấn đề về hiệu quả thì chúng ta xem xét về những cái chỉ định, chống chỉ định, những các cái hồ sơ về tính an toàn và cũng như cái khả năng tiếp cận, và cũng như là cái việc mà chi trả của người bệnh. Dạ vâng.
Share your experience about comparison between AP.
Yeah.
Okay, so I can almost understand all the translation. Thank you much. Yeah. So currently, because particularly in my slide, I have shown three kinds of treatment nowadays. However, I have emphasized that is not fair for the presentation of data, because this is not head-to-head, not head-to-head. Particularly currently, we just have 4 months of the reimbursement of the new Restrider, right? So because initially we used atezolizumab, indeed, we have to evaluate it very clearly. So we always routinely have to do the endoscope to survey the EVO, GV, and the second, we also do the cardio, I think a sonography, right, together. So after that, we make sure the patient will be safe. And if the possibility of the bleeding is very quick, very obvious, so we will treat the EV firstly, then maybe several weeks later to do the treat. Currently, we have the double immune. So if for these patients, we want to shift to the double immune. However, don't forget that because immunotherapy, the IRAE will be increased maybe twice. Just use atezol, but maybe twice of the IRAE. So we also take care about the management of the IRAE. So you can see maybe the high dose prednisolone used, the percentage is elevated. So now I think the care of the immunotherapy is a major lessons we oncologists and pathologists have to do. But I think by identify indeed the contraindication of each therapy is very important. Actually, this is quite difficult to do head-to-head comparison of that, because maybe the indication of some patients suitable for each treatment is not adequately can get the randomization, I believe. So identify the contraindication first, and then talk to the patient and discuss about the anything cost or something like that. But Taiwan is no cost is not the problem, because free for these two treats. So we will take a conversation or discussion about all the side effects, etc., particularly the past history of any immune problem, etc.
Thank you.
So I think it's time for the discussion. So we move to the next session. Thank you very much.
Thank you to all the speakers and our moderator for the engaging and insightful discussion.